apologies for that. The video is back on now. So I think we should just jump right into it. It's a long discussion, and I think what's happening? What's happening? Clicking. It's a long discussion. So basically, our objective this afternoon is we want to improve the routine care of the feet for people with diabetes. We also want to improve how well we educate our patients on food care. We want to improve the rate at which doctors are able to identify patients that are high risk for food problems, because we see that a lot of these patients are actually not identified. That is, the healthcare provider did not know that this patient is high risk for food issues. The patient who did not know, and then it seemed now like a food problem came out of the blues. We want to improve recognition of early food problems and infections when they occur. And then in people that unfortunately suffer food problems like infection and ulcers, we want to improve the treatments and their outcomes. So we're going to go a bit in this direction, sort of lightly. So just a bit from the epidemiology, looking at the burden, the risk factors, and then finally how we prevent and how we treat the food alteration. What do you think? Do you agree that food problems are one of the most feared complications of diabetes?
Yeah, they are actually very common, and yes, probably they are practicing a big center. You see see it more often, because most of the those practicing in peripheral centers are not very skilled at managing it. So, because of the specter of potential amputation, many people would rather go to the big center, but the large volume centers like
absolutely. So they have serious implications. People, I think the closer complication that people really fear as much is maybe renal complications and also loss of vision. Okay, but diabetes food problems give a lot of implications in terms of mobility, stress it gives to patients, the stress it gives to hospital, and the stress it gives to the society at large. Imagine someone losing their limb, for example. Most of the times they are unable to do most of the activities they used to do in the past. And we know that globally, the burden of diabetes is increasing. So that means for us here in Nigeria, we need to be ready, because as the people with diabetes are increasing, then that means the number of food problems that are happening are increasing as well. And I think the fact that we need multidisciplinary treatment approach for diabetic foot ulceration sometimes is quite challenging as well.
Yeah, it's difficult to have a one-stop shop everywhere around the country where you can manage this holistically. There's also the cost implication.
Absolutely, actually.
It's a huge economic burden, actually.
Absolutely. It's quite costly. There's no doubt about that, both in terms of the direct costs to the patient, the cost of treatment, and all of those things. Then we will now talk of the costs of lost man hours and all those kind of things. So those actually they have huge implications for the patients once again. So going to the prevalence of diabetes in Nigeria, we have this excellent systematic review by Professor Loko and colleagues that showed us the wide variation of prevalence of diabetic foot ulceration in Nigeria. And we can see here that the rate varies from about 3.8% to 9.8%, depending on various parts of the country. And this from several studies. So diabetes is common. There's no doubt about that. And by the time you look at the whole population of Nigeria, if we put the average of this being around maybe about 5% or so, if you agree that the population of Nigeria is about 200 million people, that's quite a number of millions of people actually. So diabetes is very common, and we know that the proportion of people that will develop diabetes ulcer each year is significant. There's a UK prevalence incidence that puts about 2% of people with diabetes developing ulcer each year. Okay, but many other series, particularly in third world countries, quote figures as high as about 5%.
Yes, even an American study saw 1.2 million cases out of 24 million Americans who are diabetic. So that works out at about maybe 5%.
Absolutely,
so it's common.
Absolutely. And in the lifetime risk of developing significant foot ulceration is about 25%. That means about 1 out of every 4 people with diabetes will have foot ulcers, problematic ones in their lifetime. And we have some case series in Nigeria. It's thought that out of all diabetic admissions, that's about 13% are related to food problems, even though a lot of series reports much more. And then by the time you look at the duration of admission, many of them, I can remember my days when I was doing residency, many of them spent literally months on the bed while waiting for their wounds to heal. So it's a major cause of hospitalization. And sadly, it's a major cause of amputations as well.
Exactly.
And then mortality is quite high. In fact, it's said that mortality after an amputation is higher than some cancers. Now, the mortality quoted on this slide is among people admitted for diabetes foot infection and ulceration. But mortality post-amputation, 5-year mortality is way more than 50% actually. And I can just think of a few patients I know that were amputated a couple of years ago. More than 50% of them are dead by now. So the mortality is actually quite very high. So we have this spectrum of problems you have in diabetic foots, and I think it will be helpful for doctors to be able to recognize this when they are there, and so that the necessary actions can be taken to protect the patient, so to say, or to give the right treatment. So deformities are actually very common, both among people with diabetes and people without diabetes as well. But I think it's way more common among people with diabetes. We also have the Charcot arthropathy. We have people that can have ulcers that are not healing and are not infected. We have ulcers that are infected. It can be tricky to distinguish between those two, whether there's an infection or not. Then we can have cellulitis, which can be localized, can be extensive, and then we can also have various shades of gangrene. Digital gangrene are very common, especially in peripheral arterial disease. We can have forefoot gangrene. We can also have gangrene of the whole foot. Gangrene can also be wet or dry. The dry gangrene usually has a better prognosis compared to the wet one, and the patients are more likely to be septic. So looking at this, which of these deformities do you think is, of these problems on this page, do you think is most common? Bunion, callus, corn, ingrowing toenails or toenail problem, dry skin, ulceration?
Well, I would say corns are very common, both in the diabetic and non-diabetic population. They are very, very common. And the problem is that most people who have corns will know it's difficult to resist the temptation to
do something about it, right?
And
it's difficult to. In fact, most even doctors tamper with it many a time. But in the context of diabetes, actually, it's something that one needs to be very careful about. Then I think dry skin is actually especially common among diabetes as well. And when it's there, actually, many times it signifies the presence of autonomic neuropathy. So just within the last 30 minutes or 1 hour before me coming here, I still touched a patient with diabetes foot leg, and it was just very dry like that. And I had to educate her. She had paresthesia. I had to educate her that keeping this moisturized will actually reduce your symptoms and also reduce your risk of ulceration. Okay. I think bunions are also common a little bit. Both bunions and corns and calluses can actually be worsened by footwear. Footwear can rub on it, and absolutely footwear that is too tight. So these things are common, and it's important for us to be able to recognize this in our patients. Unfortunately, a good chunk of patients with diabetes don't have their foot examined. So the doctor didn't even ask them to, doctor can even glance at their feet one. Doctor also did not ask them to take off their shoes. And then that means the problem can just be lying there, and then it's just unattended to. So I think that's part of the things we want to address in this presentation so that we can serve better.
What do you think about the death relative lack of podiatrists in Nigeria? Do you think this has any impact on this at all?
Absolutely. It's actually one of the things that I wanted us to. I'm trying to get back on this slide. Excuse me just a moment. Back is not working for me. Let's go back. I think I went forward, then I can't get to go back again. Just one moment, please. Just 1 moment. Okay, so I can do it today. That's fine. I can do it with the mouse. That's fine. So yeah, so about the deaths of podiatrists is a big issue actually, and I've seen many people that studied anatomy, physiologists that have been encouraged to go into podiatry. But I think because the training is not really there too, that's the centers for training is there. This is a big problem. So there are patients that, for me to get out of the very few podiatrists we have in Nigeria, for them to get someone that can see them, it has been tough. So yes, it's actually part of the health system issues we're going to mention, or along the line actually pursue with the presentation. So we're going to look at this case study now. Mr. Abu Ibrahim is a 63-year-old man presented at the clinic with an ulcer on his midfoot. So the ulcer we can see just right there. The man said that there is no issue of any trauma, but about 2 weeks before then, on waking up in the morning, he just noticed a blister on that spot, which busted later, and then the wound has just been expanding in his own words. Prior to that, he has been diagnosed with diabetes about 10 years before then, and he has been seeing his GP every 3 months. No previous foot education, no previous foot examination, no recent HbA1c. And then, of course, Mr. Abu was surprised that he had this ulcer. Maybe the doctor was surprised as well, but actually the stage was set for this kind of outcome.
Yes, I think it's at the end of the day, even with all the sophistication in the diagnostic tools and all that, the biggest diagnostic aid we have as clinicians is our clinical acumen. And most clinicians should know that, I mean, in very well-controlled patients, anybody who has had diabetes for 10 years or more is probably at significant risk for some of the long-term complications that set the stage for diabetic foot ulcer.
And then we should be actively looking out for and counseling patients about it, so that when you see this, this is likely happening. Okay, so let's look at some of the risk factors for diabetic foot ulceration now. So these are some of the risk factors. Duration of diabetes, like Dr. Livia just said now. A lot of people say that by the time the duration is greater than about 10 years, the risk is much, much higher. Now, I'll say two things in relation to this. Number one is that most times we don't know when diabetes started. We know when we diagnose it, but we don't know when it started. That's one. And then secondly, it's still important for us to know that the longer the duration, the greater the chance of complications. So many patients will tell you that, but 7 years ago, or so time ago, when I had a wound, it healed very fast. So I'm surprised that this is happening right now. The chances of having poor wound healing, especially in foot-related issues, is higher with a higher duration of diabetes. And if diabetes indeed started very recently, it's not likely that there's so much neuropathy or so much microangiopathy and those things that can contribute to poor wound healing. Also, additionally, it's also a non-modifiable risk factor is a patient with a previous foot ulcer. If you had had a foot ulcer before, it's high risk for foot ulceration until otherwise proven. Also, of course, a patient with previous amputation is very high risk for foot ulceration. In fact, it is said that most patients that had one amputation would have another amputation of the other limb within the next 2 to 3 years. For the reasons are there, because number one is that the factors that contributed to amputation in the first limb are likely still there on the other limb, and usually they put extra load on the other limb because now they only have one there. Also, peripheral neuropathy is a very big, perhaps the most important risk factor for foot ulceration. Also, lower extremity arterial disease, lead, or what we also call peripheral arterial disease. Visual impairment increase your risk of falling, not seeing your foot very well, making mistakes with your foot, unable to inspect your foot, unable to even notice issues on time.
Not being able to trim the
nails properly. Thank you very much. I've seen that a lot. So the man could not see very well and he's trying to cut his nail with a blade. Of course, he messed it up. Okay, foot deformities was mentioned earlier. Poor glycemic control, both short-term and long-term. Diabetic nephropathy and being on dialysis is an independent risk factor. Tobacco use, particularly smoking, older age, we know that peripheral arterial disease and things like that. So older age is a risk factor anyway. And then if the patient has poor diabetes knowledge and also poor self-efficacy, so they're not aware, they were not thought, they didn't know that this can cause this, they're just totally ignorant about.
This last one is so important. There's a study done in Iran, Queensland province, where they just assessed knowledge and practice. And at the end of the day, it was incredible. It was the correlation between the knowledge and practice of diabetic self-care was the relationship between it and the prevalence of foot problems incredibly.
I totally agree with you on that. Actually, in fact, if we talk about the most modifiable risk factor, it is that, because patients that are well educated. Because now I can give an example of several patients we saw recently, and I can think of the one that's the day something happened to the feet, they took this precaution, they came to the hospital the next day, and the one that was applying one about knees, putting it on, putting it on lantern and doing hot fumigation, which wasn't the problem. So the knowledge and the self-efficacy is actually very important. Now, this slide tells us about the pathogens of diabetic foot infection. And we're going to start from the base of the triangle and we're going to work our way upwards. So we know that we mentioned just now that diabetic neuropathy is critical, is a key risk factor for diabetic foot problems. So when there's motor issues, sensory issues, autonomic issues, it leads to skeletal deformities. I'll explain why along the line. Calluses, ulcers, dry skin, cracks in the skin, and all of these things increases the risk of breakage, increases the risk of infections. Now, secondly, we can now have osteoarthropathic changes, particularly Charcot's disease, which gives abnormal loading to the feet. So you get more pressure on some part of the feet, it's not going to be distributed the way it's meant to be distributed. So you can get, by the time you are having some clawing of the feet, you can have some pressures on the head of the distal phalanx, of the metatarsal head as well. And also sometimes you get excess at the heel. It increases the chance of ulceration. Then talking about arterial insufficiency, I mean, that is clear cut on its own. Impaired healing, even sometimes we ask us, we have patients like that, we're giving antibiotics for a foot infection, but we know that there's a serious peripheral arterial disease, and we ask ourselves, is the antibiotics really getting there? The road is blocked. Okay, so arterial insufficiency, it's critical for wound healing. Then, of course, metabolic issues like hyperglycemia, which you know that it impairs wound healing on its own. Then, of course, we now have patient disabilities and maladaptive behavior. So, poor vision, previous amputation, poor knowledge, poor footwear, not offloading enough. So I've seen patients with diabetic foot ulcer, even plantar ulcers, and that's when they now wanted to start exercise so that the ulcer will heal all the time. So that's counterproductive. And of course, we have our own failures in our healthcare systems, not educating the patient enough, not achieving adequate glycemic control, not even having foot care teams that have dedicated. So all of these things work together to increase the risk of our patients having foot problems, particularly foot infections as well. As we are continuing, I will suggest that if you have any questions along the line, let's put it into the chat box so that I think when we get to half time, we'll take some of the questions and then we can conclude the presentation. So, so going forward now, what's the pathway? What happens between a patient just being diagnosed with diabetes? So just today, I diagnosed someone fresh with diabetes. What's the pathway between that time of diagnosis or just having diabetes without any complication to developing a foot at risk, then towards getting frank ulceration? So this chart looks at many of these perspectives, and it clearly outlines the role of diabetic neuropathy. Okay, you can see when there's a sensory problem, the person is unable to protect his foot. Okay, so like I say to many people, you can wear a shoe now and then you're not feeling comfortable. Nobody tells you before, you just massage your foot yourself, just squeeze your toes a bit. Sometimes you don't take off your shoes because it's not tight. Sometimes you say you're not wearing this shoe again because it's summer. But someone that has lost pain sensation, lost temperature sensation, lost proprioception, basically lost all the protective sensation, there will be repetitive trauma and the person will not feel it. So the person can wear tight fitting shoes for even 5 days, will not feel anything. So I'm comfortable, it's not disturbing me. And it thinks it's resilient, whereas no, because you're not feeling it. And then you'll wake up one day and you'll find a blister and you think the blister came from heaven or whether it matched something in the village, whereas it's because he has lost protective sensation and he has been abusing his feet, so to say. Okay, motor neuropathy also causes its own issues because it's wasting of the small muscles, which leads to foot deformity, including clawing and eye arcing of the foot. So that eye arcing of the foot leads to abnormal distribution of pressures, which leads to calluses sometimes, and also, of course, can lead to frank ulceration. Of course, the role of autonomic neuropathy is understated. It's understated because it leads to decreased sweating and dry skin. A dry skin is more prone to laceration, tears, and cracks. Okay, it's more prone to callus formation, and of course, it's key to the development of ulceration. Also, we know that in people that have autonomic neuropathy, blood flow is not what it should be, and because of that as well, perfusion can be perfusion will not work the way it should work. There can be endothelial dysfunction, and all of those things can contribute to it. Now, there's a peripheral arterial disease pathway just right here on the left of the screen, and once the arterial supply is inadequate, most people are able to get by, but just one little wound or ulceration can give the foot away. And that's why when you have a patient with severe peripheral arterial or significant peripheral arterial disease, we need to be aggressive to make sure that there's no invasion of the foot, because the things that can rescue the foot or that can help the wound to heal is already compromised. So just go further in talking about diabetic peripheral neuropathy and foot disease just now. I'm sure most of us will agree that peripheral neuropathy is one of the commonest chronic complaints of diabetes.
Yes, I think it is, and the tragedy yet again is the underdiagnosis.
Absolutely.
Many people have it, and we think the same way that examination of the foot for the ulcer will help to obviously determine a foot at risk, but this is probably one of the most common substrates for diabetic foot ulceration. So we don't check for it. And the sad thing is that the patients also often give us clues. I mean, oh, doctor, when I'm walking, I feel funny. It's as if I'm walking on rough grounds, as if I'm walking on mattress and all that.
Sometimes there's a disconnect between the signs and symptoms. So some patients, a lot of patients have symptoms, but there's no sign on examination. Some have signs without symptoms. And then a lot may not even be, a lot can be subclinical. And that's why it's critical to check the 10-gram monofilament, which we're going to talk about along the line. Also importantly is that impaired fasting glucose, that's pre-diabetes status, has also been associated with some extent of peripheral neuropathy. But importantly, up to 60%, though in some studies a bit higher, in some other studies, of diabetes will have peripheral neuropathy, and is a risk factor for structural food issues, like we said earlier. And so it's important for us as clinicians to be able to recognize if our patient has diabetic peripheral neuropathy, irrespective of their symptoms.
I think there's also a confounder which we should all be aware of. By the time we start seeing older patients, middle-aged, elderly patients, we often ascribe paresthesias and numbness in those age groups to radiculopathy,
absolutely, spinal issues,
cervical spondylosis, and all that. So we should go a bit further and make sure it's actually not peripheral neuropathy we are dealing with.
Absolutely, absolutely, I agree with you, sir. So the symptoms, some of the symptoms of diabetic peripheral neuropathy, these symptoms are often classified into positive and negative symptoms. And the positive symptoms is something that is there. Negative symptom is something that is not there. So the positive symptoms include pain, which I think most of us should know, often described as burning, sometimes can be prickling, tingling, shock-like, aching. They can also have hyperesthesia, that's hypersensitive to touch. So when something touches them, they just feel quite uncomfortable with a touch that is supposed to be normal. Additionally, some people can experience sensation of numbness or deadness. And many times they struggle to describe this. I'm not sure whether you see a lot of patients like
it's
that.
Actually, we see this a lot, especially, I think, personal experience, we see this a lot with relationship to the upper limbs anyway.
Right.
We set off on a search for coronary artery disease. Many of them have some kind of ill-defined numbness over the arm, over the leg. But I'm sure there are also people who have complained about that with respect to the lower limbs.
Absolutely.
We don't quite know where to place them, and we just...
Absolutely. Just give me 1 second. I'm told there's a problem with the slides. Just a second now. Just a moment, please. Have we been locked down since? Have we presented to ourselves? Just hold on, please. Can you hear? Can you confirm? Oh, it's just a slide that is not showing, right? Just a slide. Okay, so I'm just going to adjust that now. Apologies, serious apologies for that. We did share it. So how long has the slide been out for? Please just give us a moment to resolve this technical issue. Okay, so I'm so sorry. I learned that the slide has not been showing for a while. I really apologize for that. I think there was a technical glitch. I'm not sure exactly what really caused it. Thankfully, we'll be getting the slides, but I don't want to draw us back. I don't want to draw us back so that we'll just be able to focus on the issues and get there on time. So I'll just go back to the last slide briefly. We'll talk about diabetic polyneuropathy being the commonest complication of diabetes, and that about 60% of patients with diabetes will develop some polyneuropathy, and it's a very important risk factor. It's a very important risk factor for foot ulceration. So I'll go to the next slide now. So we have positive and negative symptoms, and I was talking about this just now, that the positive symptoms are described as burning, tingling, shock-like. Some people can have hypersensitivity. The negative symptoms are things that are not there. So I can't feel my leg. I feel as though I'm walking on cotton wool. Some people will say, or as if I'm walking on the clouds, or as if I'm wearing socks and I'm not wearing socks. Some people will say they have gait imbalance, that they just close their eyes a bit or look away, they can almost fall. And then a lot of people experience painless injuries, like the one you mentioned earlier. Exactly. Some that I've actually seen some such stories as well before. They just see blood on the floor, blood somewhere, and they see that they injured their leg and they couldn't, or they didn't feel a thing actually. So those are some of the key symptoms of the sensory components of the peripheral neuropathy.
I think the issue of course, just for the clinicians in the house, just to remember about diabetic pseudotypes.
Yeah.
So that issue of some people will tell you that in the dark at night, they have falls. And they can't explain it, they just keep falling in the dark. So that could be a clue that will direct the skilled clinician to actually actively look for peripheral neuropathy.
I agree with you. Interesting of you to remember this pseudotypes. They should mix it up with syphilis in this day. So here we have. So we have the features that we can see on examination. Typically, sometimes you can see the dry, scaly feet. You can see calluses and corns, and you should look out for those. So that means you should look at the upper part of the feet and also the under part of the feet. And now you can see oftentimes when there's motor manifestations as well. You can see wasting of the small muscles of the feet, like you can see in the picture right here. So you can see the tendons looking very prominent, and it means that some of the interossei are actually they've thinned out. Okay, and that pulls up the toe and gives you some sort of clawing, leading to the high-hacked foot. Also, the other sign that we can pick if we look for it is loss of protective sensation, particularly checking with the 10-gram monofilament, which we'll talk about along the line. Also, vibration sense should be checked, and then other sensory modalities, including light touch, pinprick, and the joint position sense, which are usually affected much later than the 10-gram or the vibration sense. So here we have the role of polyneuropathy again in foot disease. I think we've talked about this quite a bit. The decreased sweating, the alteration in blood flow, leading to increased pressure on the sole of the foot, and of course that repetitive trauma in the context of poor blood supply often leads to foot ulceration. So those are the key things that lead to ulceration of the foot in patients. Is the slide showing properly now? Okay, so we have these parts now. We have the various deformities we have in diabetic foot ulceration. I think it's just emphasizing what we've said earlier. All of these deformities are common. I think the commonest on this page, I mean, you mentioned the commonest earlier being things like corns, calluses sometimes, and then the hallux valgus is also rather common as well. Beyond that, footwear problems are important. So that's part of the key risk factors for diabetes foot ulceration. So we talked about the peripheral neuropathy earlier on. Now we talked about these deformities, which usually a lot of them are triggered by the presence of the motor manifestation of the peripheral neuropathy. But footwear are also important as well. And I think we doctors, many times you don't look at what your patient is wearing in the office. And if we don't look at that, the patient is not going to pay any more attention to it than we have. There's an interaction between the closest object to the foot is the footwear. Okay, and that's when we're thinking of foot problems, we cannot absorb the footwear in this. So the footwear is important both in prevention and also in treatment as well. And we know that the footwear can protect the feet from dryness, from nails, from things that can injure the feet, basically in the environment. But
and in our environment, of course, especially for those who are practicing in the more rural setting, you should remember that many people still go about barefooted. So
you're right.
Farmer patients and so on and so forth, we should try to remind them of the need to protect.
Even many old people, even in cities, that feel that I've been working on my leg for so years, so why are you to tell me to wear this? Okay, but as much as the footwear can protect, it can also cause frictional rub on the foot, and I think that's where the issue can also be. And that's why the footwear should be, in one of my Oga's language, should be sensible, should not be too tight, not should be too free, and it should not cause rub. Should not rub repetitively on the foot in a way that can cause blisters. Some footwear can also increase pressure on the foot. And I think what needs to be done for that is that basically, first thing, I tell female patients particularly, should not wear boots that are particularly too high heel, particularly when there's established neuropathy, because it would place all the pressure to the first metatarsal head. Now, because you're now working with
on tiptoe,
exactly. So that's important, and we should give them guidance on that. So the way pressure is distributed actually is partly determined by the kind of footwear we're wearing. And we should also know that there are some therapeutic custom-made footwear that can actually unload, that is, remove pressure from the site where you have an ulcer and actually help the ulcer to heal within a shorter time. So I think these are some examples. I hope it's clear enough on our screen. So I mentioned that females should avoid high heels, males should avoid pointers or pointed shoes, because what this pointed shoes does is that it actually compresses, it puts pressure on the toes and make them juxtapose on each other and apply pressure. So the pressure on the toes is actually so much, and that's why we avoid that when we ask them to get shoes with what we call wide toe run. And what I tell patients is that they should be able to wriggle their toes sort of in their shoes. Yes. If you're wearing a footwear that you cannot wriggle your toes in front, and it means that it's slightly tight for you in front, and that increases their risk of experiencing blisters and ulceration. So that's one. And then usually it's said that when they want to buy shoes, we should counsel them to get their shoes towards the end of the day, so that if they experience any mild amount of leg swelling, as some studies say that your foot is slightly bigger at the end of the day compared to at the beginning of the day, just because of gravity, even undetectable edema and things like that. So that's important. But they should make sure that the foot covers the entire width of the shoe cover the entire width of their foot. And people that are wide foot should know, so that they get shoes that will fit them properly. Now, people that have hallux valgus like this, they need special shoes that can accommodate that extra space that the extension of the first metatarsal head. Okay, so we have some footwear categories in various footwear recommendations for various foot risk categories. But the main thing I want to emphasize on this slide is that even though because of the lack of podiatrists and lack of people that make customized footwear, limited amount of people that make customized footwear, I think it limits the options that people have in this part of the world. But I'll still emphasize that by the time people are having deformities in their foot, you have to pay attention to their footwear. Okay, you have to pay attention to their footwear, and usually they need some sort of footwear that will accommodate. So they're not people that now just go and buy one shoe. They have to sit down, try it, look at how it feels before they buy it. So, but ideally, they should actually get therapeutic footwear and get footwear that are custom made for them, so to say. And there is a lot like that. The footwear I showed in the previous slide, one of these ones, this middle one, some type of this middle one can accommodate those kind of foot. So this is like a kind of retail one. Okay, but many of them actually need footwear that is customized made for their foot, so that it just accommodates whatever deformities that they have. And people that have had previous ulceration before need custom made insoles, so that there's something, the insole made at the bottom of the foot, that can mold into the shape of whatever deformity of previous ulcer that they have in their foot. But like Dr. Levia mentioned earlier, we don't have enough podiatrists and not enough people make this custom made footwear, particularly for patients with diabetes in our environment. But we should find a way to work with some. Okay, so lower extremity arterial disease.
This has become a game changer. Of course, we know about the sad interplay between cardiovascular risk factors and a good number of people who are diabetic also have high blood pressure.
Absolutely.
A number of them also have dyslipidemia. So basically, we've had in recent years an explosion of peripheral arterial disease, under-recognized as well, and it's basically it has cost some kind of fuel in the fire of diabetic foot ulcers.
I agree with you, and many times people can have lower extremity arterial disease and then they are absolutely asymptomatic. Absolutely. So there's, I can't count the number of patients that just check them out here, just check that dorsal space, posterior tibia, cannot palpate, popliteal, that weak or absent, and they have absolutely no symptom. And by the time you do the ABPI or the Doppler ultrasound scan, you find out this person has significant peripheral arterial disease. So it doesn't always correlate with the degree of symptoms, and that's why we should check for it. And lower extremity arterial disease is way more common among people with diabetes. Some series codes typically about 3 times more. Okay. Sadly, among people with diabetes, the lesions, that's the stenosis, are more likely to be diffuse. They're more likely to extend to the infrapopliteal regions, which is typically less amenable to interventional therapies. And of course, typically we have a lot of calcification, which is usually less amenable as well. Often thrombogenic lesions that are quick to attract platelets and quick to block up
vulnerable plaques.
Thank you very much. And basically, the prognosis of lower extremity arterial disease among people with diabetes is not as good compared to people without diabetes. And I think that's a big factor that contributes to foot ulceration or non-healing foot ulcers in them as well.
I think it's especially for the pregnant people. I think we should also remember things like Lereutis syndrome. So, especially if you see a relatively young person, middle-aged male coming with erectile dysfunction, intermittent claudication, think about that. You actually deal with somebody with a very advanced peripheral arterial disease.
Absolutely. So, so we have the spectrum of peripheral arterial disease. I think we know about this already. So they can get these symptoms that can be quite non-specific. They can have pain, aches, tiredness in the leg, weakness, numbness, discomfort. They sound like symptoms of peripheral neuropathy as well.
Exactly.
So it can be very tricky, absolutely. But if you get exertional, most patients with diabetic neuropathic discomfort in the leg, it typically gets better with exercise or moving around. Now, most people will tell you when they wake up in the morning, they can have the burning sensation or whatever discomfort in their lower limbs. It's actually slightly worse when they take the first few steps. But after about, I don't know, walking around for a little bit, it gets better. Whereas for intermittent claudication or vascular pain, it typically gets worse, even though we know there's the so-called breakthrough angina equivalent in that, so some people can walk through it sometimes, okay? But of course, by the time we are getting clear-cut claudication, rest pain, the ischemia is usually quite bad, and basically the flow limitation you have in those arteries are worse. So in assessing a patient with lower extremity arterial disease, we should be aware of the risk factors, the symptoms, which we talked about in the last slide. But on inspection, we want to look for these features, which are typically called tropic changes. I'm not even sure where that word came from for it. But typically, you see someone with thin skin, smooth, shiny skin can look pale, there may be duskiness or cyanosis.
Hairless.
There can be hair loss, yes, at the distal phalanx or in the middle phalanx. The nails is often thickened and dystrophic. The skin can be discolored, the muscle too can be atrophic, and of course, it overlies upwards. Neuropathy can cause the atrophy of the muscles. Of course, the arterial disease can cause because, of course, the muscles are not getting enough nutrients. Of course, by the time you touch the foot, it can be cold, particularly proximally. You may not be able to feel the pulses, like I described just earlier. And of course, later you can have changes like ulceration, gangrene, typically at the tips of the toes, which can be wet or dry. And of course, there can also be bruise. And of course, the Bogart's test can also be done to demonstrate that this patient is likely has a peripheral arterial disease. So we should remember the 5 Ps: the pulselessness, the paralysis, which is typically weakness, the paresthesia, which can be mixed up with a neuropathic symptom, even though they often overlap. They can have pain and they can have pallor as well. So I'll go to this next slide now. So we can see these feet. I'm not sure what we think about these feet. The foot on the left of the screen is obviously dusky. You can see the nails. Second nail is hyperpigmented. The first nail is quite thickened a bit. I think the feet is shiny as well. Okay, and then there's a bit of discoloration just at the head of this first metatarsal area. We can see similar thing on this left foot here, but the right foot looks fine, or is it?
Well, it's well by comparison, but even around just before the junction with the tibia and the fibula, I can see some changes as well on the dorsum.
Absolutely.
Which suggests that it's also not completely well. And of course, I would say there's a little bit of guttering.
Absolutely, there's guttering. So there's some evidence of neuropathy, at least on this seemingly normal.
Exactly.
And the arterial status, usually one cannot tell until you try to feel the arteries. Even though I agree that yes, there are no clear-cut tropic changes on that. Yes. But the guttering, so there's features of neuropathy. And hardly will you see someone that has either serious neuropathy in one foot and does not have any in the other one, or severe peripheral arterial disease in one leg and then does not, because these are metabolic and systemic issues. Exactly. So I would encourage us that even the seemingly normal leg, we should. Now, the woman we did intervention for, which I'm going to show a picture of her foot along the line. The woman we did for that has had an amputation of one of the fingers before. You know, the foot that was seemingly normal now is one that the problems are now quite obvious, and the one that was problematic before is now fine. But so importantly, the point of this slide is actually to remind us that even when the foot looks normal or the relatively normal side, there's usually a lot of disease there. Why? Because the diabetes that is causing this problem is a systemic issue, and the problem it causes are diffuse. I think, let me see if there's, should we take some of the questions now? Let's take some briefly if there's any. Most of the questions there before are about slides not showing before. So here we have
something about volume. See something about volume. Somebody said not clear hearing.
Volume clearly. Okay, so I want them to look at that. So someone said, who will be classified as being high risk for diabetes? And then second question, what question do you have for it?
What advice do you have for non-diabetic patients who is at risk because both parents and siblings are diabetic as regards lifestyle
and the likes. Okay, so people at high risk for diabetes, even though it's not directly within the context of this, are people that I'm not sure what would. So it's a accumulation of risk factors, like we know, and I think one of the strongest will be family history actually. So family history of diabetes perhaps gives someone possibly more than a 50% risk of developing diabetes. Okay, by the time we now have other risk factors with it, getting older, presence of obesity, sedentary lifestyle, and the presence of hypertension. Of course, if you've had impaired fasting glucose before at any time in the past, increase the risk even further. So I think those will be GDM. So those will be very key risk factors for it. And my advice for someone that has a strong family history of diabetes will be to be on an intensive lifestyle modification. And usually I call intensive being doing virtually everything as if you have diabetes already, apart from maybe the checking glucoses and the medication. But the diet should be as healthy as possible, because by the time someone has two family members with diabetes, the risk is well in excess of 50%.
I've seen the people that say that good parents is 70%.
Absolutely,
parents, 70, it's as bad as that.
As high as that. So, so all the possible risk preventive modalities should be adopted as much as possible. So I think that those are just it. So I'll say encourage us to put our questions in the Q&A box so that we address them along the line. So yes, so someone asked that why are the infrapopliteal blood vessels less amenable to therapy? Well, it's not just less amenable to therapy. I think their response to therapy is not as much as the suprapopliteal, but I don't know if Dr. Dafferson is likely will be able to comment about that along the line. Okay, but so the vessels there are a bit smaller, they are much further down,
they're more distal.
And they're more distal.
It's logical in that sense that the further away from the main trunk, arterial trunk, you are going to get less perfusion. And because their caliber is also smaller, those atherosclerotic changes we are talking about are likely to result in even greater degree of affectation of the cross-sectional area than the bigger arteries.
Absolutely. So now going to the next slide. So metabolic control and food disease. So basically, glycemic control interferes with all the other risk factors. I think we know that already. Poor control, good about poor control, particularly over the years. So long-term control, if it's poor, increases the risk of all these long-term complications we talked about, particularly peripheral arterial disease and peripheral neuropathy. Okay, and it's common for us to see someone that's had very poor control for 15 or 20 years and coming with a foot ulceration over the last 1 week since the foot ulceration started. He's been taking his drugs. In fact, he's been on insulin. His sugar is well controlled. Okay, but it's not going to change the neuropathy that is established. It's not going to repair the arteries for me, unfortunately. So the poor long-term control, you cannot undo the effect of that. That's what I'm trying to say. And of course, now short-term control affects the outcome of injuries and infection. So that's clear. So that we can do. Okay, but the effect over the years, the foot is now clogged, the arteries are now clogged. We cannot really do so much about that. Okay. So also the metabolic parameters that are important, I think I listed them earlier, is glycemia, short-term and long-term. Also, unfortunately, patients with CKD, particularly those that have end-stage renal disease, very high risk for foot ulceration. Why? Because uremia itself impairs foot healing, accelerates atherosclerosis, it causes some neuropathy on itself.
Impairs immunity as well.
Impairs immunity, thanks very much. And sometimes they have edema as well that can alter pressure, and of course, they also have a lot of malnourishment, but particularly by the time they're getting to the ESRD. So the risk of foot ulceration among patients with kidney disease, particularly those now on dialysis, is also very high as well. Of course, dyslipidemia also increases the risk of foot ulceration, and I know that Professor Wolabi and co did some studies looking at the overall cardiovascular risk using UKPDS, which includes dyslipidemia. It has some correlation with the risk of developing foot ulceration. So going to diabetes self-management education, sorry, there's a typo in this slide, DSMA. So diabetes self-management education is actually critical to prevention of foot disease, is a risk factor. So patients that are not educated, the doctor often fail to tell about the risk to the foot, what you should do, what you should not do, they have more risk, okay? And a lot of people believe that diabetic foot ulceration are the most preventable complications of diabetes, because most of them are preventable actually. And that means we have a lot of work to do in terms of educating our patients, empowerment of our patients for self-care, for them to know the things they should do to their foot and the things they should not do to their foot. Patients that know this, actually, the risk of having foot problems, ulceration, and amputation is almost reduced by about half. Now, it's not a one-off thing, unfortunately. So it's not something you told the patient in 1998 and you expect the patient to still be applying to now. It's something we continue to tell the patient over and over and over again. Now, there's a lot of studies in Nigeria that has documented that knowledge of foot care is poor among Nigerian patients with diabetes mellitus. Not just Nigerian patients, it's a global issue, but at least we have local data for that. So we as healthcare providers, we have a lot to do in this regard, and I'm believing that all of us will step up our game in making sure that we equip our patients to take care of their foot so that to prevent these problems. Now, going forward, what are the healthcare system issues that contribute to foot problems? Now, Dr. Ludibia mentioned earlier about the paucity of podiatrists, okay? There's paucity of healthcare workers, doctors, nurses. Now, specialist diabetic nurses are quite limited. Podiatrists they are rare. So they are very rare, okay? Of course, among we healthcare workers as well, there's still some ignorance and poor knowledge, and that's why we're talking about this, so that all of us, we update ourselves and then we ginger ourselves such that we're able to give the patient the service that they require. Now, busy clinics too is an issue.
Yes, the challenge we have, service delivery is difficult to define thing. Are you assessing it in terms of volume, the number of people you see? Are you assessing in terms of the effectiveness of your impact on there? So it's of course you have to straddle that thin line between both sides, especially as we lament the continuing loss of exactly. So we are those that are around are getting stressed and all that. But the point is, it's if we put ourselves in this patient's shoes, literally, losing a limb is a catastrophic event. And when you know it's like a slowly evolving car crash. You can see it coming, and we should do everything we can
to prevent it.
So whether we need to do, perhaps the most effective or economic way to do it is maybe by doing mass education. If we are not able to do one-on-one, just the same way you do antenatal, like you educate women as a whole, busy clinics, busy very black centers, perhaps they can consider that just doing periodic mass education of diabetes.
I think it's a reasonable one, actually. It's a reasonable one. And also risk stratifying patients is something that could help. So at least even if you can't educate everybody every month and things like that, patients that are higher risk, patients that have neuropathy already, and has food already, and then nobody has told them that you should do this or you should not do it. I think that's
patients that are still smoking.
Absolutely, absolutely. And of course, also our audit systems and clinical governance to make sure that the service that people are meant to get. And then we talk about the podiatrists earlier, but also therapeutic footwear is difficult to get in our environment. Actually,
they are very few.
They are very few. And that is part of the reasons why a lot of patients with diabetic foot ulcers are admitted for longer than they would have had to. Because if you have a therapeutic footwear that can offload your patient, and the patient can continue to receive care for this plantar ulcer while ambulating and still going to office and things like that, I think a lot of needless admissions may probably be reduced. So I think those are some of the systemic problems. So I think we'll talk next about what the foot at risk is.
Yes, because I mean that's the meat of the problem. We need to be able to identify them. That's part of the risk classification you're talking
about. Absolutely. So we want us to be able to identify foot at risk. In people that have high risk foots, they need regular inspection and examination by the doctor, by the nurse, and also by the patient himself. And those patients need extra education, like we talked about just now. For the patient, the family, and even us, the healthcare providers, we need that education so that the patients basically can get better care, they can take care of themselves better, and then the risk of these things will be less. And of course, we know the patients should wear appropriate footwear, and of course, we need to be able to know the pre-ulcerative things, the features you see just before a foot goes into frank ulceration, and we do the right thing, and then the patient gets better, rather than developing an ulceration that will lead the person to land on a hospital bed, or that will get several days off, or that can lead to amputation. So I think these key things are key to preventing foot ulceration. So what are the things we need to do to recognize the at-risk foot? We can see this big foot here, and I'm hoping that by the time we are remembering this picture later on, you remember to tell your patients to take off the shoes. Okay, so when we're seeing patients with diabetes, we should remember to get them to take off their foot, their shoes, even if it's not at every visit, but at least once in every quarter or once in a while, look at the patient. At every visit, you should look at the patient's feet, see what they are wearing, comment on it, and at least if it's difficult, every quarter. Now, for patients who have high-risk foot, those should have their feet examined at every visit. So there are some social demographic parameters that can put the patient at risk. I mentioned older patients, patients that have had ulceration before as an historical feature, and things you found before an examination. So
I would say also people like farmers, people who, I mean, soldiers, people who wear boots for long hours.
I'm about to write a letter for many people in that parametric line that they need to, because you have senior parents, so everyone else, and you're still trying to wear boots and stuff. Okay, so that's important. We've talked a bit about examination earlier, so I won't spend so much time on this. Okay, but previous ulcer amputation is a huge risk factor for diabetic foot ulceration, end-stage renal disease I mentioned earlier. Not having previous foot education, so that's a typo. It means the lack of previous foot care education. Social isolation, grandpa is living alone, nobody's living with him. Is high at risk. And of course, people who have poor access to healthcare. And then Dr. Olivia mentioned earlier about barefoot walking, which is still very common and rampant. So of course, we should assess the vascular status. We should look at the skin, we look for deformities, and of course, we should assess the footwear. So we should ask them about the footwear, ask them what kind of footwear they wear at home when they go out, and look at the footwear they're wearing to your clinic. Okay, so that's important. We should also assess for neuropathy. I think I'll talk about this a little bit along the line. Okay, but you should assess for neuropathy by asking them about questions about symptoms, something they don't tell you. Okay, and also we should use the 10-gram on filament. We should assess vibration with the tuning fork. We should assess their ability to discriminate pinprick. We should assess light touch, and we should also check their reflexes as well. So going further, we can see this foot that I showed us earlier. How bad do you think this foot is?
Well, it's still
Mr.
looks,
Mr. Boostfoot.
Yes, it still looks a bit superficial, but I think that's probably if you're just doing a superficial inspection as well. If we look further, we'll probably see that there's a lot of induration around it, and because there isn't so much flesh over there, you suspect that there could be some bony involvement, even as shallow as this
it looks. Right. So we can see the discoloration around it. The base of the ulcer itself is clean. It looks clean anyway. It looks clean. Okay, but the discoloration around it is a bit worrisome. Fortunately, this man's ulcer actually healed quite well. So, but these are there, and then there's some cellulitis. There's swelling all over this medial side. It might be difficult to appreciate in this picture, but there's a lot of cellulitis. So this is there. But if we encounter a foot like this, even though hopefully I'm hoping that we intervene before the foot gets to this stage, but the basic thing we need to assess is neuropathic signs and symptoms. We should assess the vascular status. Fortunately, when this patient was assessed, the blood flow was very good, and it's part of the things that made his wound heal within a couple of weeks. His glycemic control was poor at this time, but thankfully, over a few days, we were able to get the glucose under control, and he did very well, actually. So, but in assessing a foot of a patient with diabetes, these are the things we want to look at. We want to look at the ulcer itself, how it started, how long it has been there, and how it has progressed. So I mentioned in the history of Mr. Abu, it started as a blister. And we know that from the series in Nigeria, that most diabetic foot ulcerations start very innocuously. One look like a ball, a blister.
Blister is very
but it never starts as something, it hardly ever starts as something serious, maybe an accident or something just big. It starts very small, something that is totally almost like what you should disregard at the outset. And that's why part of the things we should counsel our patients is no matter how small, I thought people have had diabetes for a while, no matter how small the lesion is that they are seeing on their feet or the injury is, they should report to the hospital. They should report to the hospital so that they get the full care and so that it doesn't progress. Okay. Part of the things we should do when we are seeing such patients again is to assess risk factors of foot problems in them, assess their metabolic control, look for systemic features. So it should be standard to ask whether patients who comes with a foot ulcer or a foot infection, whether they've had fever, malaise, aches and pains, nausea, vomiting. It always comes with a baggage. It comes with a lot of things together. And those are the things that will guide how intensively you should manage the patient. So by the time we examine systemic features, for example, if you need inpatient care, okay? Now, of course, I've talked, when you're examining the ulcer, you look at the size, the surface, whether there's swelling, whether there is discharge, and whether the discharge is clear, whether it's purulent or purulent, and etc. And whether there's a foul odor. Anytime you have a foot ulcer or foot infection that has a foul odor, it carries a poor prognosis actually. Not like, I'm not saying that you have to go and amputate, no, but it means that there is a deep-seated abscess that is undergoing putrefaction and is a red flag whenever you are examining someone with a diabetic foot ulceration, no matter how good, how benign the outer part of the foot looks. So also in evaluating the foot, I think I've talked about most of this already.
Yes.
Look for the change of peripheral arterial disease, palpate the arteries. The way to know, the way to be proficient in palpating those arteries is by doing it in patients with normal arteries. You are seeing the regular diabetes patients, you're checking, so that the day is not there, you're able to pick it confidently that no, this patient's pelvis is not feelable, this patient's posterior tibial artery is not palpable, or the cochlear pulsation is weak or absent. So by the time you pick that, you know that this patient likely has peripheral arterial disease, and then you are doing your ABPI if you have it. Otherwise, you send the patient for a Doppler ultrasound scan, and by the time you do that, you can assess the vascular. So it's not until the foot is now not doing well after taking care of it for 2 or 3 weeks. That's now you have a brain wave to assess. Let's check this patient's vascular status, and then we now start running helter skelter. Okay, if you pick a femoral bruit, it suggests that there's advanced arterial disease. And of course, we should check for temperature. Now, the temperature can be deceptive because we know that the presence of foot ulcer and some cellulitis will try to make it warm. Peripheral arterial disease will try to make it cold. So, in the absence of an ulcer, it being cold is worrisome. But in the presence of an ulcer, the temperature being normal is not fully reassuring because that coldness, that normal temperature can be something that is supposed to be hot, but because of the arterial disease, is now bringing it towards cold.
I think it's useful. Thankfully, the person doesn't have an application on the other shape. It's usually good to just
beautiful. It's good to compare.
So that will tell you whether what looks normal is really normal.
Absolutely. Absolutely. And of course, you can check the capillary refill as well, which normally should be less than 2 seconds. You can check usually in the toe because you may not be able to see through the nail. So it's just the pulp of the most distal part of the toe that if you press, you can see whether the refill is fast or not. And if the refill is very slow, and then that means you should be wary of the vascular status of the patient. Going further, I think I've talked quite fully on how to assess for neuropathy. We look for wasting, look for Gauthrin, which is the very prominent tendons and wasting and atrophy of the interossei muscles. Assess sensation with the 10-gram monofilament, which I'll show us about. Assess the vibration sensation at the bony points. Assess light touch. Now, you may not be able to do all of this, but at least you should do about 2 of the modalities to show that you have assessed the nervous status of this patient, that's of the sensory status. Of course, autonomic neuropathy, I've mentioned the evidence earlier on. If you get a very dry foot, sometimes there's bounding pulses. It can tell you that this patient has some autonomic neuropathy. So we can see this foot here now. We can see the Gauthrin here. Now you can see the hallux valgus here. You can see this bony prominent here. It can look benign, but if a patient is wearing a shoe that does not accommodate, there can be repeated friction there, and it's a common point of ulceration. You can also see the clawing of the toe. I don't know. I hope they can see my mouse. And the clawing of the toes can make the top of the shoe rub against those middle phalangeal areas. And of course, you can see that. Now, also, the sole is not showing. When a patient that has this amount of wasting, the first metatarsal head is often more prominent and gets a lot of pressure and predisposes to ulceration. Now, in this same patient that is getting abnormal pressure, now imagine that the sensation of pressure of the same monofilament is lost. Okay, so that's important why it's important to check that. When a patient does not feel that monofilament to the point of kinking of the monofilament, it means that the patient has lost that protective sensation. So now the patient is getting abnormally high pressure, and on the other hand, they cannot sense pressure. So that's just a perfect recipe. Double wala, exactly. So the investigation we should do in patients presenting with diabetic foot problems includes a metabolic panel, use and heat, urinalysis, blood glucose, A1C, complete blood counts. Many times we do the inflammatory markers as well, the ESR and the C-reactive protein. The infection assessment, a wound swab is usually not so reflective, and a biopsy is better when it's takeable. But when we cannot do a biopsy, then special techniques are used to take the wound swab so that we're not just taking commensals or things that colonize the skin. In people with moderate to severe infections, it's worthwhile to take a blood culture to increase our diagnostic yield. It's important to check the ankle brachial pressure index, which I think there's a full stepwise approach to doing that on our webinar on peripheral arterial disease. I think I'll refer us to check that. But basically, you check the pressure in the brachial, in the 2 arms, and on the leg, and then we'll calculate the index. Normally, it should be around 1. By the time you're getting less than 0.8, it means that there is significant peripheral arterial disease. And by the time it's less than 0.5, you should be really worried. Okay, absolutely. And then Doppler ultrasound scan as well is important, and that can tell us various extent of peripheral arterial disease that is possible. And in people that have moderate to severe, it might be worthwhile to get an angiography, a CT or MRI angiography. And foot radiographs are important as well. It can give us guidance whether there is osteomyelitis or not. But we should put in mind that the X-ray, even when there's osteomyelitis, the X-ray often lags behind. And it might take up to 2 or 3 weeks after the onset of osteomyelitis before there can be X-ray changes. Some people have...
It may be useful when you're also worried about gas.
Absolutely, thank you very much. So gas gangrene, absolutely. So if someone has that amount of cellulitis and then you see gas in the tissues, that's gas gangrene that is forming on this, gas forming organisms there, which can guide the antibiotics. Exactly. And should tell you that you need to be very aggressive because it's a marker of severity as well. There's something I wanted to say. So I think that's about it. Of course, foot radiograph can also show us things like Charcot's arthropathy and things like that in patients that have that. So going forward, management is a multidisciplinary approach. I think we know that already. The clinicians, physicians, doctors, the diabetic nurse, tissue viability nurse, those are not really present here, but usually at least a wound nurse, a nurse that's interested in wound care, particularly for patients that have those particularly difficult wounds. So plastic surgeons, wound/plastic surgeons, the podiatrists, which we said they are rare, the microbiology team should also be in the loop, and various other specialties may also be involved as well. So, are definitely poorer. Okay, so going forward, but when there's an established infection, then in people that have ulcers, we want to relieve any pressure on the ulcer and you want to protect. We want to revascularize. We want to usually. You want to educate the patient and the relations. You want to prevent recurrence. You also want to identify and treat other diabetic complications. One of my guys, Dr. Adele, will always say that it's unusual for you to just have diabetes foot ulceration without any other diabetic complication. They come with a lot of baggage of complications. Most of them are coronary artery disease. They have peripheral neuropathy, they have peripheral arterial disease. So all of those things should actually be identified and treated as well. The resuscitation, particularly if they are acutely ill, and basically rehydration, treat any anemia, try to address any renal impairment, treat infection, and try to achieve blood glucose control, which I'll get to along the line. But the key point is that it's almost foolhardy for you to have a patient that is just very sick, that's septic, and then you're trying to do other things, you're trying to offload or things like that. No, you need to address and resuscitate that patient first. So that
also at this stage, the acute illness, you also have to revisit the medications. So
absolutely.
Those of them who are
thank you very much. So we should assess their medication at that time. So many medications that they were on outpatient basis is often not appropriate in this kind of situations. So that's one. Secondly, of course, is offloading. Offloading is important. There's a saying that in diabetic foot ulceration, it's not what you put on it, it's what you take away from it. Okay, and taking away from it is taking off some of the blood sugar, taking away the load from the foot, taking away dead tissue in the context of debridement. Okay, so going here now, so we want to offload the foot, and offloading just means stop carrying weight on that foot, and stop carrying weight on that sore, on that problematic area. Okay, so we limit ambulation, we advise bed rest here, which has a lot of pros and cons. It's not the most advisable way to manage many people that don't have very serious infection. But unfortunately, we have to do that many a times because of lack of many of these offloading footwear. So if you do bed rest so much, yes, you achieve what you want to achieve, but sometimes the glycemic control can get worse because patient is exercising less. Sometimes you can get DVT and things. It's frustrating. Patient has lots of earnings, and then lots of things just go round and round. Absolutely. Thank you so much. So ideally, for many of them that are not so, that the infection is not so severe, it's just some ulceration, offloading footwear is actually more appropriate. I didn't put pictures of this, but we have those contact casts, which can be total or partial contact casts, and then there are a lot of specialized footwears that can actually offload areas of some plant ulcers, specifically made for that patient's particular ulcer, and can give a lot of relief. But the key thing I'm saying here is it's important to offload a patient with diabetic foot infection or ulceration. And the example I give to patients is the example of a wounded horse that is bad, but you're still carrying all your belongings on the horse, and you're wishing the horse gets well soon. No, the horse will not get well soon. Why? Because you're putting load on them. So patient should not walk on an ulcerated foot, so to say. So that's one. Second is revascularization. It is known that lower extremity arterial disease or peripheral arterial disease is present in more than 50% of patients with diabetic foot ulcerations. By the time the ulcer is not healing as fast as it should, you should ask yourself why. Is it you are not controlling the glucose very well? Is it there's an infection you fail to treat properly? But I'll tell you that most of the time it's because the amount of vascular supply that wound is getting flow that you require in peacetime, that is when there's no ulceration, is much, much less than when you require when there's an ongoing war, there's need for tissue regeneration, some blood cells will die as pus, and so there's a lot of activity going on there. It's as if you are rebuilding something. So you need a lot of resources, and you need your blood flow. And that means a patient that has compromised blood flow before, but that was able to maintain homeostasis, by the time there's an ulceration, that blood flow is likely not going to be enough. Okay, so there's some things that can tell us that someone needs revascularization. Number one, if you see clinical features of ischemia on the foot ulcer, so you're seeing some dusky area, the ulcer is at the tip of the digits, and things like that, it can suggest to you that this patient may need revascularization. Also, if you have a non-healing ulcer, that is, you are doing all the right things for the ulcer and it's not healing, in the context of some peripheral arterial disease, the person, whether or not you can see features of ischemia or not, the patient should be considered for revascularization. And of course, if you have poor readings on your ankle brachial pressure index, on your transcutaneous saturation, and on Doppler ultrasound scan, in the context of a wound that is not doing well, the patient also should be considered for revascularization. So when your ABPI is less than normal, in centers where you're able to do the ankle brachial pressure index, wound healing is likely going to be impaired, but it's going to be difficult to achieve wound healing if your ABPI is less than 0.5. And in places I've worked before, I know some people, the ABPI is just like this, the wound and the wound is not doing well, it's just straight to amputation. Okay, but of course, if the patient has lesions that are amenable to revascularization, they can actually give some of these patients a chance if gangrene has not set in already. So it has been shown in studies that we have a better rate of limb salvage when you revascularize. Of course, it's not everybody that you revascularize that you're able to save the limb. It's not everybody that will be a candidate for revascularization. Okay, but I think losing a limb is a big thing.
It's a big thing, and indeed, with revascularization, you can actually be able to limit the extent of loss.
Absolutely.
Which is also important for rehabilitation.
Absolutely.
You want to make it less difficult to rehabilitate.
Absolutely. So someone that was meant to get a BK end up having some ray or a midfoot amputation, or someone that was meant to get a AK because of better with a BK, which is so. And both open and percutaneous vascularization, which you do here, leads to improved outcomes. And there's no study to choose one over the other, but I think percutaneous is minimally invasive, and most patients find it acceptable actually once the finances are there. So this is the story of the one we're talking about earlier. You can see the foot. Now, the size of the picture are quite a bit different, okay? But on the foot on the left, yeah, that's the left. Initially, a foot on the left, initially, yeah, you can see how dusty it is, cracking, a lot of hyperpigmentation, evolving gangrene actually, around this area of the great toe, okay? And it was almost extending to the second toe as well. And the patient was actually offered amputation somewhere, and then someone somewhere referred. So the patient came in, of course, the dorsal pedis was not there, even the popliteal was not palpable at all, the feet was cold, she was having rest pain, particularly on sitting down, she could not sit down, she sat down, she had to put the foot on the stool. So she was having rest pain and all of that. So the patient had peripheral arterial angiography done, and we can see this image here. The first image here, you can't see the artery here. You can't see the artery. There's a full filling defect here. I just used the yellow, I put the yellow marker on it to show where the artery should have been. And the limb was surviving on collaterals, even right from this very proximal level, was surviving on collateral, just the collateral that is going down. So, but after the vascularization, you can see this artery now opened up, blood flow is restored, and this is about maybe 4 weeks to 6 weeks after. This is now about 3 months time now. I don't have a recent picture, but about 6 weeks after is when I took the second picture. The nail was removed, a new nail started to form under all these cracks and things you saw here and resolved. The toe was getting pink back. The toe is actually very pink now. And of course, the leg is now better. Now, the leg that was apparently fine then is the one that we're now worried about. Not like it was, but this other one has gotten better and overtaking it. So peripheral intervention or vascular intervention can actually do a lot of good in patients that are candidates for it. So that's about revascularization. So treating infection is important. Revascularization is also very important in patients that have peripheral arterial disease, especially those that that have these ischemic features, the ulcer is not healing, or you did a Doppler and then there was some evidence of peripheral arterial disease. So infection should be assessed for, and I think that most foot ulcers we see here, virtually all are infected. Not virtually all are infected. A lot of things related to our environment is there. But of course, you can see features of infection sometimes: fever, chills, leukocytosis, purulent or malodorous discharge. Worms can all suggest that there is some infection there. It's better to assume there is infection than to assume that there is not infection there. And of course, in patients that have moderate to severe infection, they need inpatient care. By the time we are getting cellulitis that is occurring to a significant extent around the wound, you are better off with inpatient care and certain parenteral antibiotics. Now, the antibiotics of choice usually should be based on your antibiogram in your center, based on common sensitivity patterns, etc. Okay, but typically we use cephalosporins, beta-lactamase inhibitors like amoxicillin, amoxiclav. Fluoroquinolones are usually very good, clindamycin, and then sometimes for very serious infections, the carbapenems, including meropenem and imipenem, should be considered. Metabolic control is also very important. It's critical. One meticulous glycemic control. We want to keep the fastings less than 110 milligrams per DL. Postprandial, ideally less than 160. Most of them will require insulin inject therapy at this point, because once there's any ongoing infection or any ongoing complication like this, usually you need insulin therapy, at least initially, so you get the glycemia controlled on time and then you're able to keep it there. Invariably, they need more intense glycemic monitoring at this time. So this is not the time that they'll be checking their sugars every 3 days or stuff like that. You'll be checking it several times a day. And of course, if there's any electrolyte imbalance, you want to correct it so that the foot has the best chance of healing. In terms of the wound itself, the local wound care, we've talked a lot about offloading already. The patient should not be walking on the ulcer or on an ulcerated foot or an infected foot. They need to rest that leg at that time. Ideally, offloading using the special footwear is preferred, but they are not so available in our environment. If there's significant edema in the leg, you want to elevate it, even though you don't want to do this in the context of peripheral arterial disease, okay, but when there's significant edema, you want to elevate it so that the edema reduces, because edema increases the moisture in the wound and will retard the rate of healing. You want to clean the wound, you want to debride it, you want to dress it with various agents. The debridement can be sharp debridement, can be chemical, using various gels that can lyse the necrotic tissue. And of course, we also know that there's also biological debridement using sterile maggots, which we don't typically do in this environment. Okay, there are various agents for the wound dressing. Usually, it's best to take the advice from the specialist wound nurse or the plastic surgical team concerning the dressing agents. Many times I see some people dress on wound too tight. If you dress a wound too tight or too thick, it can increase the amount of moisture in the wound, and that one can also retard wound healing as well. So I think that's about it.
Just what, because the little things, the simple things shouldn't be forgotten. Many of these wounds are deep. Many of these wounds have a very rich anaerobic environment. So one should always remember tetanus toxins as well.
Absolutely, absolutely. I've seen quite a number of diabetes patients actually that caught tetanus from diabetic foot. So it's very important, particularly those ones that got contaminated. So the farmer, somewhere. Okay, but so
local space.
Absolutely, absolutely. So it's a good needles for the tetanus augment. So tetanus prophylaxis is actually important in the management of diabetic foot. I think we'll have a lot of discussions from the questions, but I'll summarize with this slide that in managing diabetic foot problems, we need a well-organized team. We need to use an holistic approach, and we should not just focus on the ulcer. There's often multi-organ disease in these patients, and we need to integrate a lot of disciplines: physicians, general practitioners, the nurses, the wound surgeons, the podiatrists, which there is a paucity of. All of us can come together to actually improve, to reduce diabetic foot problems and improve the outcomes of these patients. So I think we'll end with that, and we'll start to take the questions. Any other final comment, Dr. Lidibia, before I take the question?
I think it's you said it all. It's important to contextualize this in the big picture, which is that we have all that complications. And So for instance, you see a lot of diabetic patients who either are not on statins or are on statins but are not getting to the therapeutic goal. LDL Absolutely. Is up in the sky,
right,
and so on. So we are not helping because the atherosclerotic process that underlies the PAD is not being addressed. And you have a lot of people who go for months and years without doing hemoglobin A1C. They just come to the hospital with their charts and you see blood sugar of 5.7. Everybody's happy, high fives all over the place.
Absolutely.
And then they go home, and we know that that is not a very good way to assess long-term control. You have those of them too who start having spuriously relatively low blood sugars and they think they are healed. Meanwhile, it's actually the onset of diabetic nephropathy, which is also a risk factor for this.
Absolutely. So, many of the diabetic foot ulcerations, like a good fraction of them, I don't like to say many, their sugar is actually a bit normal at that time because of sepsis, renal impairment. So more than half of them, the renal function is poor at the time of presentation or admission. So someone asked that how does immune dysfunction play a role in slowing the degeneration? I guess it's meaning in affecting the progression of how much does immune dysfunction play in diabetic ulceration? Well, I would say that diabetes is an immunosuppressive disease, particularly now, both long-term and short-term. So long-term, if someone has had diabetes for a long time, even if you control the sugar now, the immune system is not as robust as it should be, and the response will not be as robust as it should be. And also, when there's acute hyperglycemia, it also dampens the immune response as well. So these things actually increase patients of acquiring infection generally and also specifically for the foot. And
and it starts even from the innate immunity. It's not just the specific immunity.
Absolutely.
So lazy leukocytes, so what they call the diapedesis, all those normal things that happen with white cells getting attracted to a site of infection.
In my surgical class, I used to say diabetes retards all the stages of wound healing, and they used to tell all those stages at that time, and then it slows down each and every one of them. Someone asked that there is lower extremity arterial disease. Is it preventable? Would you consider it to be preventable?
It is to a large extent. It is
to a good extent. I'm not sure what I would say large or not. Well, because it's something that happens with aging.
It's part of aging.
Okay, but it's at least it can be. Particularly the one related to diabetes, yes, it's preventable, because when we say preventable, it's never absolute anyway. So it's preventable, at least with good metabolic control over the years, low blood pressure control, good lipid control over the years. All those things can slow down lower
smoking cessation.
Thank you very much. So by then, because you see a lot of LAD at the age of 40s, 50s, 60s, that's not due to aging, obviously. Absolutely. So yes, it's at least partly preventable. So someone is asking that was the ideal way to take care of diabetic foot ulcer in a low resource setting. Dr. Ludwig, I'll push down.
Difficult. It's really difficult. The thing is, when do you catch it? At what stage are you seeing it? So if it's at the earliest stage, which we hope is when you catch it, so a blister and all that, then applying these basic principles, you should be able to get home and dry.
Absolutely.
So achieving good blood sugar control, that cannot be overemphasized. If you can culture something, maybe there's a little discharge, you can actually culture it. So you need good microbiological backup. I mean, if your culture is not right and you're treating empirically and you're not getting the organism, then it starts expanding. And then at that early stage too, if the other local factors you can take care of, a swollen limb, so maybe somebody, because this can actually happen even in a setting of congestive cardiac failure, where you have pedal edema and all that. So if you can address some of the other issues that are contributing to it, or once it gets to the point where you have gangrene or you start having bony involvement, then at that stage you just have to refer. You have to refer to a center that can do much more than you are able to do.
Absolutely. So I would want to still emphasize on the role of prevention, because we can actually prevent a lot of this ulcer. So low resource setting like Nigeria, which we emphasize a lot of prevention, and our prevention goes with all the things we talked about earlier. We doctors paying attention to the patient's foot in our clinics, educating the patients about the importance of foot care in diabetes, identify patients that are high risk and paying extra attention to them. So those will go a long way in reducing. Now, when wound form or issues happen on the foot, I can assure you that if the patient presents very early, your risk of the total cost is much less. I mean, I make a joke example to patients when they come to clinic. I ask them that if they told you that a stadium got burnt, how do you think the fire started? Do you think it started like an atomic bomb, boom, or it started with just one small spark somewhere? And almost all of them will tell me that it started at a small spark somewhere. So almost all food, no matter how bad you see the food, actually started with one little lesion somewhere that was likely either disregarded initially or got the wrong treatment initially and things like that. So if it's peaked at that stage, and the cost of treatment is almost never immense, except if the arteries are really, really bad. But if you ensure meticulous glycemic control, offloading, treating infection, and all those at that stage, usually it heals within a few days. So I think I'll emphasize more of the prevention part. But of course, when there's foot ulceration, when there's a serious foot infection, unfortunately, it's costly to treat, and there's no two-way thing about that. I will also say, emphasize what Dr. Lidwia said, that studies have shown that in specialist settings, the outcomes of this are better, and what's the word now? The overall cost is even less. So if patients had this kind of small wound and then came to the hospital early, okay, patient can spend X amount of money or incur X amount of cost in treating it altogether. But now the same patient decided not to go to the hospital and went to the roadside somebody or went to the pharmacist and did this, did that, the food got worse, it got more swollen, things got worse basically. And patient now presented 2 weeks later in the hospital. Oh, the food is worse now. And then you require more intervention, more costs, and you even require an amputation, which is costly. So I think it's not to be penny wise, pound foolish, is what I'm going to say. So someone asked now, what is the modern investigation for neuropathy aside the clinical examination you enumerated? Thank you very much for that question. I think that's a very interesting one. So I'll start from the basics now. That first of all, there is no very serious role for anything I forgotten. Okay, the important thing we need to do to assess diabetic foot for neuropathy is asking questions and examining the foot. That's almost 100% of what we need to do. Now, of course, there are some other things that we can do. There's some more sophisticated examination you can do. You can use what we call a biotessiometer, which is a quantitative kind of vibration sense. So you're checking the vibration sense, but now you're checking that particular frequency. I know the frequency person can sense, the frequency person cannot sense. So it's like an electronic tuning fork that can set to varied frequencies, so to say. So a biotessiometer, but it's not very common. The other thing that can be done, even though it's just for academic and research reasons, is what we call the neurophysiological test. Those are nerve conduction tests. But again, it's not necessary in clinical settings. It's usually not necessary in clinical settings, really. Okay, what we can do, which most people are not doing, is to do the ones I mentioned earlier, using the Siemens-Wenzel monofilament to check presence of protective sensation or not. One, if you check the tuning fork. Two, and if you can also check maybe light touch or pinprick, you can check 3 sensory modality, you've done your patient a whole lot of good. Okay, but I think the more advanced one are the ones I mentioned now. There's also one, I can't remember the name now. I think it's like a plexismography. I can't remember what we call it, but you can check the pressure, the distribution of pressure in the foot. So that can add a little bit to what we've gotten already from this clinical assessment I mentioned earlier. So I think it's called a plexismography, but I can't remember the name very well. But it's something that the patient stands on, and then the same measures pressures in different aspects of the feet. And the patient is putting too much pressure on a certain part, it can tell you. And that spot when the patient is putting too much pressure is at risk. And then you can modify the patient's footwear to suit that one. You can also do a gait reorientation for the patient so the patient can redistribute pressure better. So I think before they distribute the slide, I think I can put a slide on that since so I think that's a good question. Huh? So there's a question, another question here, that what is the mainstay treatment for Wagner stage 0 to 2? I actually didn't put the Wagner stage in this slide. So the mainstay treatment still follows the overall principle. So someone that is just Wagner stage 1 to 2 will require some local wound care, will require glycemic, may not require admission, depending on the location of the center and depending on the center, but I will tell you that most places will still admit a Wagner stage 2. So it's just the other part of the treatment I mentioned earlier. So that will be meticulous glycemic control, offloading still at least for 2. Offloading, if you're not offloading fully, then patients will be on a footwear that at least does not place any pressure on the area of the ulceration. Meticulous glycemic control, and of course, even with that, I would suggest that you do a vascular assessment. Apart from clinical, at least an ABPI plus or minus a Doppler will be necessary for such patients. So that's what I would recommend for a patient with up to stage 2 DM foot ulceration. Someone here mentioned intravenous insulin pumps as a conservative management. I'm sure I didn't say that. Maybe it's a slip of tongue if I said that. So in terms of managing diabetes, there's no role for, so intravenous insulin is used in diabetic emergencies, usually in HHS, ZK, or patients that are admitted into ICUs. So in people with diabetic foot ulceration, particularly when there's infection, most of them require a more aggressive control for their glycemia. Many of them can require insulin therapy, which is usually in form of basal, bolus, insulin therapy. Sometimes you're able to combine basal and oral. That's like the MPH, glargine insulin, or levemir insulin plus oral agent. But for most, particularly if there's moderate to severe infection, I would prefer to put on a purely on insulin regimen, at least until things calm down, maybe for 1 or 2 weeks until cellulizing and all those other things are resolved, and then we are on a pathway of healing for the patient. So I think that's what I'll say regarding that insulin therapy. Can you please tell us about the use of contact casts for wound healing? Okay, so I won't be able to go into a lot of details on that, but I'll say that when there's ulcers, particularly on the plantar surface on the foot, okay, one of the key things that we can do is to use casts to offload the foot. And using casts to offload the foot is just like a POP. Some are the total, there are some non-removable and removable ones. So the ones is like a POP, and then some of them are the ones that you just strap to the foot. You strap it there, and the undersurface of the cast is molded in such a way that the place where the ulcer is not under any pressure at all. So you can walk, the patient can walk with it, even with a very nasty plantar ulcer, can walk around with it can walk around, do different things without putting any pressure on the ulcerated place. Okay, so they do that. Of course, usually when they're using that, there's some criteria that has to be met, and it comes with its own risk as well. So sometimes you can actually put pressure on some other part of the foot. Okay, so you can put pressure on some other part of the foot. One. Secondly, is that the ability to inspect the ulcer to see it live the foot is less. So people wear the cast for one day, and by the time they're taking off the next day, they already have some blisters in some other area. And then thirdly is that any infection of the ulcer has to be treated first of all before you apply the cast. And that means that usually when the patient has an infected ulcer, you don't put on the TCC from day one. No, you first of all treat the infection, you do other things. By the time the ulcer is now getting healed, rather than now allowing the patient to have a protracted bed rest or a protracted period of not ambulating, you now wear that one while the ulcer is healing gradually, because these ulcers can take weeks, sometimes months to heal. Okay, and in places where they do limb conservation a lot, that is, they want to avoid amputation by all means, which is good. It often means that a ulcer that has very little chance of healing is given a chance, and the patient is actually still ambulating, still doing different things, and the ulcer is still there, healing gradually. And with the right kind of cast, you can actually make sure that that ulcer is not being under pressure while the patient is going around their activities of daily living. Since there's interest in it, I think I'll add some pictures and a slide to that. Someone asked there, how long should antibiotics be given? And also, can the wound be skin grafted? It's a very good question. So the need for antibiotic and the duration is totally guided by your examination findings and what you can see in the food. So you definitely need antibiotics until evidence of infection in that food is cleared. That is, you've cleared whatever infection is there. I'll tell you that typically, depending on the severity of the ulcer, you typically need from the severity of the ulcer or the severity of the food infection, you typically need an antibiotic for from about 7 days to up to 4 weeks. But by the time there's osteomyelitis, you need minimum of 4 weeks antibiotics. Many will recommend up to 6 weeks. And I tell you, we say that by the time you are seeing the tendons, one, or by the time you can probe to bone with a blunt stick, there's some sterile stuff that you can use to actually try to probe the wound and see whether you can get to bone. Usually, you can assume that there is osteomyelitis, irrespective of the X-ray finding. So in those kind of cases, you actually need to give for long. Now, can the wound be skin grafted? Definitely. A lot of patients with diabetic foot infections or diabetic foot ulcerations actually need what we call advanced wound care. And advanced wound care includes things like using vacuum-assisted wound closure, that's VACS. So vacuum-assisted wound closure. Some also require grafting of the wound, particularly if the dimensions of the ulcer extend beyond a certain range. That's primary. Secondary or primary, but healing by scarring will be very difficult. So you need to put a graft there. But that's why we need to work closely with our colleagues in the plastic surgical department. They know how to guide us regarding these decisions, and we work with that along with the patients. So yes, the wound can definitely be skin grafted. I have a lot of patients with diabetic foot that have had their foot grafted, and it does well. But usually, of course, arterial supply needs to be top notch. So you can't be grafting a wound in which the arterial supply is like 50%, because it will be painful if you remove skin from the thigh. You put on the some of the foot and yet it doesn't take. So you need to be assured that the blood supply is very, very good. If hyperglycemia
we lower immunity of the disease, could
shorter appointments for people with poor control help. Now this is a tricky one. I will tell you that in people that have poor control or diabetes poor control, shorter appointment is not necessarily the solution. The solution is actually for us to take the right steps that we need to take. That intensification of treatment should be done appropriately. Yes, now when you're intensifying treatment, sometimes you need shorter appointments. But that short appointment is not because of the hyperglycemia, it's because you're intensifying treatment. But we need to make the right decisions. So patients need to make some decision about maybe some lifestyle changes, some dietary changes. They may need to make some decisions, either accepting certain treatment that we are offering that they're not offering. Okay, but we should not leave hyperglycemia untreated. Now, talking in context of diabetic foot ulceration, of course, if you are managing any patient with diabetic foot ulcer on outpatient basis, the appointment needs to be short, invariably, irrespective of whether you are controlling glycemia very well or not. It has to be very short. Most people with diabetic foot ulceration require a brief admission. Most. Maybe it's because patient present late air, but the vast majority of the ones I see, we need a brief admission so that we can get things under control. And don't forget that even going from home and coming now and then is also loading the foot, and patient is going back and forth on that. Someone asks now that what does it take to start podiatric training in our universities? It's not my question, first of all, but I'll say that for you to be able to train on something, so for you to be able to train people, you need to have enough people in that field, okay? And then they should now be interested enough to approach universities for a curriculum. There may be one or two places that they do the training, even though I'm not aware of any, but to start any kind of training in any university, you need enough people in that field, and for them to be interested in teaching it. You need to have a few of them in
curriculum. You have to have a body, a regulating body.
Absolutely.
We have all those things. So that's the issue.
But I think this is Dr. One of our guys in Lagos actually we have this foot consortium that is budding up and budding up. So podiatrists are part of them. The few podiatrists are part of them. So hopefully by the time they get enough numbers, I think that's going to happen very soon. Hopefully. Even if it's not necessary university training, even if it's some sort of
diplomas
and fellowships.
Yeah.
So those will help. Someone asked, is it really revascularization or regeneration? Is there a place for use of platelet-rich plasma? Okay, so I'm going to, yes. So there are a lot of things that are done for advanced wound care and to improve tissue regeneration and tissue revitalization, so to say. So many of these things are done, but I don't think there is, thank you very much. I don't think the evidence base is clear cut, but I know it's been done in some centers, but frankly speaking, I don't have any experience with or even the growth factors in diabetic foot ulcers. I don't have those. Okay, but I think usually the plastic surgeon, again, they usually guide us concerning other things that we can do, particularly when the wound is not doing well. But I'll tell you that most wounds that are not doing well is not because of these kind of things. It's actually because that you've not controlled the metabolic factors, you've not restored vascular supply to the wound, or the last thing I wanted to, you've not treated the infection very well. Someone asks now that can we comment on nerve transfer for regaining sensation in diabetic foods. I'm not aware of it as a technique. It's a common technique for doing that, really. The things that may be susceptible to nerve transfer, if they do, will probably be maybe some mononeuropathies. Don't forget that the neuropathy in diabetic foot ulceration is micro. How many nerves do you want to transfer? So if someone has a lesion along maybe the ulnar nerve, for example, in mononeuropathy, you can transfer that. So I'm not aware of how much of that is being done actually, but I know it's not mainstream, if I may say that. On a research level, exactly. So, and then it will be more amenable, it's more appropriate for maybe some mononeuropathies, the trauma, that can be considered. Now, someone asked, when you pick a patient with diabetes, what low resource management algorithms to factor in prevention and progression into all the associated complications, especially for peripheral neuropathy? I think the most important low resource thing that can be done is actually, number one, patient education. Patient education is actually grossly underrated. Now, we know that health literacy in Nigeria is poor, if I may say that, as among the general population, is not as robust as it should be. But we as healthcare providers, we often just say that, okay, this patient is like this. It's equal for me to educate this patient. You won't understand what I'm saying. We do say that very, very easily, whereas we should actually find a way to communicate what the patients need to know so the patient can do the right thing. We have maybe 1,000 patients to take care of. That patient has only one person, so the patient will look after himself. We give him the necessary. So I think patient education is actually central to it. That's one. And secondly is the low-lying fruits. If someone gets well educated, first of all, which is a template, if we control the glycemia very well over the years, the time to get into this endpoint in a well-counseled and well-educated patient, I'm talking about that we told them what we should tell them, well-informed patients, the risk of getting all these things will actually be less. Not just for diabetic foot ulceration, but for all the other complications as well.
I think the other part of it is not just looking at the patient's perspective, but also looking at what we can do. I think that a lot of us in the general population, clinicians, physicians, and all that, are probably not practicing according to guidelines. Guidelines are there to guide, and if, for instance, we do a poll now, the last time most of us asked our patients to do HbA1c, I think the results will be quite alarming. So we know that HbA1c is incredibly predictive of microvascular complications. Now, your patients at present, the initiation of treatment, HbA1c was 14. 1 year down the line, HbA1c is 12 or 13. Another 1 year, 10. That patient will develop peripheral neuropathy. That patient will develop diabetic foot ulcer at some point. So the patient comes to you, does a lipid panel. You say, oh, the lipid panel is good. Good in what way? Are you assessing based on the normal yardsticks? Are you assessing this person based on guidelines for diabetes? So is this LDL of 150 that may be appropriate or not particularly concerning in another person? So this is a diabetic patient. Are you treating?
Absolutely.
So these are things we can do.
And unfortunately, by the time the patient develops long-term complications, many times they may not be under the care of the person that managed them in the last 10 years when the problems were brooding. So I think those are low-lying fruits. I think what else we can also do is in our clinics where we work, we should talk to ourselves, we should create checklists and just simple things that will remind us to make sure that this patient have had this information about this, make sure I check this patient's foods, make sure I check this patient's HbA1c, LDL, all of those things. So if we check those things and we make sure that we are doing it for our patients regularly in clinic, I think that we'll get better outcomes. Someone asked, that can I comment on the use of insulin applied directly to the diabetic foot ulcers? I've not really heard of that before. I think it will be a funny practice. I don't think it's right. And I know that insulin has certain properties, but I don't think it should be applied on the ulcer itself. So I think that will be fringe again, or I don't know. I've not heard about that before actually. The one I've heard about is maybe applying antibiotic topically. Superficial ulcers, some antibiotic ointment may be very superficial ulcer, may be appropriate, or the one impregnated in the mesh dressings. Yes. Okay. But for insulin at all, no, there's no such thing really, to my knowledge anyway. Insulin should be given subcutaneous IV in people that need them. So they are not aware of any role for this. Someone has given us a scenario, so I think it's a very, very interesting one. I think we're a bit out of time actually, but I think we'll just quickly do this still. A 60-year-old woman presented with ONC, what we call HHS now, hyperglycemic hyperosmolar state. GCS was low, RBG was 36, which is very high. She was given vinegar leaf to chew 2 days prior to presentation with the aim of reducing the said high glucose. She was admitted and blood glucose was controlled. She was found to have pyelonephritis by renal scan, EUCR, urine MCS, and severe anemia. She was managed with insulin, cephalosporins, and other antibiotics, and she was also transfused. She's got better and she was discharged after about 2 weeks. On follow-up, hemoglobin dropped again and she consistently remained weak. What can be responsible for anemia and weakness? EUCR is good. It's interesting. It's difficult to say actually.
Well, the way I look at it is, first of all, there are 2 things there. One, persistent anemia or recurrent anemia, whichever one it is. Then EUCR is good. We often hear EUCR is good. What do you really mean by good? You need to look at 1, the person's baseline, 2, the progression from that baseline to where you are, 3, the EGFR, very importantly, the EGFR. So the creatinine or urea may be within the reference range, and the person has lost 60, 70, 80% of the net loss.
Absolutely.
And very importantly, we also should know that creatinine can be influenced by all sorts of things, even though not as much as urea, can be influenced by diet and so on. And creatinine often is a little bit overestimates GFR actually a bit. Then even hyperglycemia, you can correct me if I'm not mistaken, can actually also affect creatinine initially. So there are all sorts of things there, but that anemia that is persistent for me, so I would say it's probably CKD, but technically that should have persisted for about 3 months or more. So
I'll just add a few things. So many of these herbal medicaments that people use, we don't know a lot of their consequences. And from my experience, I've seen a lot of all shade of renal impairments, both tubular issues, glomerular issues from taking one or the other. That's one. Secondly, we don't know why she seems to continue to have anemia, even though like Dr. Delube says, there could be some subtle sort of renal impairment here that may not be fully reflected in the creatinine. Okay, but some toxins can also affect the bone marrow. Some could cause some hemolysis that could have persisted. Some can cause some myopathy. So many of these herbal medicaments are not tested, and the full spectrum of the potential consequence they can have is just difficult to. So I saw someone recently that had toxic liver injury from taking a herbal medicament. So they can cause a lot of things. So I think the way to really look at this is to try to find out what's causing the weakness. If the anemia can explain the weakness, then it's just the cause of the anemia that we should be looking for, which I cannot fully rule out the effect of that toxin too, because some people can have bone marrow suppression of the erythropoietin. So I think I'll look, if the anemia is enough to explain the weakness, I think I'll just focus on looking for the cause of the anemia and see whether the toxin can explain it and what mechanisms underlie it. So hopefully if I can correct that, that might get better. There's one last question. We'll just take this as the last one. That has really gone to spend 2 hours. So this person said that if a 50-year-old man with severe pain, swelling, mild bony deformity of the feet is being managed in the past for hyperuricemia, is not diabetic. Pain is severe at night and limit movement. Aside managing the patient as one with gout, what else can the patient benefit from? Oh my God, I didn't quite get this. So severe pain, swelling, bony deformities, as an hyperuricemia before, not diabetic. Well, it's tough to say, but if he has this pain, the pain you describe now, I'm not sure how much swelling is there, but the patient can have neuropathic pain, even in the absence of diabetes. And if we judge that this patient may have neuropathic pain, I will try to take history around other things that can suggest that this patient has peripheral neuropathy. I would also want to examine the foot very well to see whether there's any sign that supports that the patient has neuropathy. So in patient with peripheral neuropathies like this, apart from diabetes, which patient does not have, we should look for other structural and metabolic issues that can cause it. Structural is typically radiculopathy from the spine, which I tell people usually is more proximally than distally. So when patients have radiculopathy causing pain in the lower limb, usually more in the thigh and upper leg than in the foot, but it doesn't always follow that way. Whereas the metabolic one are usually more distally. So the metabolic one, there's an extremely long list for things that can cause that. Alcohol, thank you very much.
Cause the hyperuricemia
as well. Exactly.
History needs to be a bit richer.
Absolutely, absolutely, absolutely. And all those metabolic panel of things like what's called B12, I say vitamin D, calcium, thyroid function tests, all of those things can give an inkling to it. Okay. So thank you very much for your comments. Thank you for the contributions. I'm so glad with the participation. We had maybe about 120 or so people attending today. So that was very good. The presentation is coming from CardioCare Multispecialty Hospital in Garki, Abuja. We focus on cardiovascular disease and internal medicine. I'm an endocrinologist. Dr. Dedubia here is a cardiologist and cardiovascular medicine. And we have 5-6 consultants, and we practice across the spectrum of internal medicine. So one of the major things we do is cardiovascular intervention. And we are one of the very few centers that does cardiovascular interventions in Abuja. That's invasive cardiovascular interventions. So things like coronary angiography, peripheral angiography, and intervention. So we do a lot of stenting, balloon angiography, pacemaker implantation, ICD implantation, CD. I'm not sure everybody knows. So ICD is implantable cardiovascular defibrillator. Okay, it's indicated in people that have had cardiac arrest before or that at high risk of having cardiac arrest. Also, CRT-D, that's a device that helps a weak heart to work better. So a lot of patients with heart failure can get their symptoms really upgraded by getting the CRT device if they're candidate for it. We also do IVC filter insertion, removal, and also
interrogation of devices
as well. So those are a lot of things we do. We have neurologists, rheumatology clinic, cardiology clinic, endocrine clinic, and all of these things. So we pride ourselves in forming collaborations with our physicians, and I think that we can create a good network that can actually improve healthcare delivery in Nigeria. So we believe in up and down referrals from the center, from us, patients back to their GP, people referring to us, we refer the patient back, and we give a clear outline of how their further care should proceed. So most of the patients that are referred to us, they get their referral medical reports, which is later back to their GP, and we are always willing to communicate back to the referring doctor so that we can work together and we can deliver care back. Ideally, this is how care should be actually, and we are taking the lead, even though, of course, if the public health sector, there are issues there, is not as good as it should be, okay, but still, we still believe that at least if we do this continuously, we can improve each other's practice, we can improve the well-being of our patients, and I think we can write a better story for healthcare delivery in Nigeria. So I really believe in healthcare in Nigeria. I really believe that healthcare in Nigeria can really improve. We have doctors from Nigeria going here and there and doing wonders. So why can't we replicate the same at home? So I think we can give our patients better care, and I'm happy with participating in this discussion. I want to believe that going further, we'll decide what additional things we can do for our patients to find time to educate them better, have information leaflets for them, find out that they understand the education, they know what to do with their foot and what not to do with their foot. We'll be able to take extra time to examine our patients' foot, ask them to take off their shoes, be able to identify patients with nerve issues, with vascular issues, identify patients at high risk, and then pay extra attention to these patients. And the one that needs to be referred, we refer them. I'm hoping that we have less amputations of our patients' feet. Absolutely. Because we're doing these things, and even the ones that are unfortunate enough to be ulcerated, the ones that are candidates for revascularization should get that, so that hopefully we get better foot outcomes in Nigeria. So thank you very much, everybody. Hopefully sometimes next month, we're going to be having another webinar that will be communicated on time. I really thank all the people that asked questions. I think it made for a richer discussion. If you have any questions or any challenging case, we can always post in the WhatsApp group, and I think we'll always be ready to respond to those. So thank you very much once again. Do have a lovely weekend.
Bye.